Today, my friends, we are going to talk about IIH, which is Idiopathic Intracranial Hypertension. What does that mean? So we'll actually start in the middle. So intracranial hypertension basically means that there's too much pressure in one's head. And usually that's a derivative of three things. You only have like kind of three things in the brain. You have brain tissue, you have blood, venous blood and arterial blood, and then you have cerebrospinal fluid, right? So a lot of times we're looking at this cerebrospinal fluid element as a way to understand why there's too much pressure. We may also be looking at the vascular system to see if it's entering and draining correctly, or if there's something growing in the brain parenchyma that shouldn't be there. These are mass lesions, and these are kind of the main three things that can affect it, right? But what we're saying in idiopathic intracranial hypertension means that idiopathic means we don't really see anything that's causing it, right? So it doesn't have a tumor. There's not a frank vascular disorder. We don't see overactivity in the meninges or problems with increased CSF production per se. We just see that there's something wrong that's creating too much pressure, right? Okay, so the reason this is important for us is because in the world where you're looking at things with headaches, with orthostatic changes in how those headaches go, temporal headaches typically, but they also may cause problems in the way people experience their vision. They may have tinnitus, and it may be pulsatile tinnitus, where you can kind of like hear your heartbeat in the ringing in your ears. And if you might guess, these are things that are related to what we see in concussion. They're related to what we see in different types of dysautonomias, and can be one of the elements that we want to include. So when we do workups for folks in this world, we're also doing a workup to rule in and out, see if there's a problem with too much pressure in the brain or too much pressure in the skull, and see if there's a way that we can ameliorate that. So let's walk through the diagnosis of what that means, because a lot of people will ask about this. And we'll ask about it on a couple different layers, right? That we're going to talk about the way that we look at it through the eyes, the way it might be established through MRI, and then lastly, how people might look at it through something like a lumbar puncture to be able to develop a full clinical picture on whether or not someone's dealing with IIH. So without further ado, let's go ahead and hop into it. So typically, what's available at the bedside, or what is available just like on a normal exam, is we can look in the back of someone's eyes. That's the easiest first place to start without getting into any like invasive sort of testing. And the reason we do that is because when we look at the optic nerve that comes into the back of the eye, any pressure that's generated inside the skull, the optic nerve that goes into the eye, may actually start to bulge into the eye. And we can see that just by looking through the pupil into the back of the eye. And I'll show you what that looks like here now. So here, let me show you this first one up in the upper left corner, I think, on your screen. This is the optic nerve. And you can see these are blood vessels, right? And those look pretty great. But this optic nerve, as this comes out, we should be able to see this clear circle, right? And then when you look on an ocular CT, we get these nice bands of the retinal fiber layers. And so we see, just like capture a picture of this whole thing in your mind, and this is a normal. And then we get into what is papilledema, or the grading of that optic nerve pushing into the back of the eye, okay? And you can see here, see how the borders are becoming less clear? Like on this edge, you can start to see they're getting a little bit blurry. And what that means is that that optic nerve is starting to bulge in that area, and it makes it look like a hill rather than a line, and it starts to get blurry. And then you can see here how this is starting to expand down here at the bottom, and we get a little bit of this expansion up here as well. And then if we slide over and look at this, like the grades expanding, you can see how it almost looks like a bruise swelling out. And so you can see this swelling that is occurring around the optic disc. This is grade 2. You can see it's getting wild on the OCT down here. Grade 3 over here, you can see that expansion even more. And in some cases, in a live view, you'll see changes in the venous pulses as well. Obviously, you can't see that in the picture, but when you're looking in the back, you can see the veins pulsing a little bit differently. And then you can see here, as it gets even further down the line, this is grade 4 on the left, grade 5, and we can see that you can't even really recognize that optic disc. And these are the cases where we are seeing significant papilledema, a lot of pressure in the head to where it's pushing out on that eye. At this point, we probably have some significant visual changes. Things are not going great, right? So this is the way we look at them. And this is really useful, especially when you can compare the picture against the OCT. Again, that's pretty non-invasive, pretty easy to do. And then if you saw something like this, that might lead you to then investigate something like an MRI or even potentially into a lumbar puncture. Like the definitive diagnosis for IIH is we do a lumbar puncture. We don't do it, but you'll do that in a hospital setting where they'll puncture a little needle inside the dura of the spinal cord, because that CSF, or cerebrospinal fluid, should communicate between the brain and the spine, so it should flow. But if we're having a hard time making it flow, the pressure is going to build, especially in that spinal segment. So when you puncture that in, that fluid's going to try to rush out, and we measure how fast that fluid's trying to rush out. And you're kind of looking for like more than 25 centimeters. And that's kind of like the opening pressure that we look at with IIH as being significant. And that will be the definitive diagnosis. But you may find that before that happens, or in concert with that, that we actually want to look at an MRI. And I think this is good to show you so you can get a visual of what happens when we start to get compression or pressure adding up in the brain. Remember, it's all contained inside of the skull. So any fluid that goes in is going to start squishing the stuff around it, right? It's like too many people on the subway, everybody's getting squished in. And so that's kind of like, those are the signs we're looking for. They're kind of like the squishing signs. So this is a paper that was done, I think, in 2022. I'm just going to show you this one, not because we need to get super deep and nerdy into the paper, but because it's got really good pictures to show these things. So this first one is what happens in the sella turcica. The sella turcica, if you just kind of look right behind your, like between your eyes, behind your nose, there's this little bony like holder, little goblet holder that holds your pituitary gland. Your pituitary gland sits in there, and then the optic nerves kind of make an X around it and then shoot back toward the back. This is where we get nerdy. But basically you've got, I don't know if you can see here on this image A where the eyes would be. And if we just drop that straight back right there, that little nugget sitting out in the front is the pituitary gland. And then it sits inside of a little bony holder right there. And then the optic nerves, so the nerves that help you see, the ones we were just looking at going in the back of the eye, they actually make an X around this pituitary gland, and then their fibers will go, you can't see them here because where the picture is in the MRI, but if we were to go to the outside pictures of this eye, you would see these big fibers coming back here to the occipital lobe. But what will happen is the same pressure that gets applied on the optic nerves behind the eyes can start to create some pressure changes on the sella turcica. Now, the reason we pay attention to that is twofold. We used to think that just the pressure alone just kind of squished the pituitary gland, and then you would see that you couldn't see the pituitary gland as well. What it now looks like is, because this bone is a little bit more dynamic, we can actually see that the bone itself looks like it kind of like expands a little bit to try to give a little more of a wall against all the pressure. Excuse me. And then we do see some squishing of that pituitary, but it's not as much as previously thought. But what it looks like is I don't know if you can see it well on this B here. If you're on a computer, it's probably easier than if you're on your phone. But basically, that sella turcica starts to look like it's empty on the inside. You don't see this nice big, ball of pituitary gland. It looks like it's squished. And then the same thing if you spin around and look at it facing the front, you can see this gray space right here is a nice pituitary gland, whereas it starts to look like the space inside gets a little bit empty in cases where we have more intracranial pressure. Now, it's worth pointing out that not everybody that has IIH will experience an empty sella turcica. So it's not like this is perfect diagnostics. It's just like a thing that we can see in some of these cases. Here it says Ajid found that empty sella was present in about 26.7% of people and about 5% of controls, right? Not a one-to-one diagnosis, you have this, boom, there it is. But it just is a clue. And as we look at these MRI findings, you're kind of looking at the overall picture, trying to see if like I've got all of these things and there's a probability that maybe I am having too much pressure and I'm having these temporal headaches and I'm noticing this pulsing in my ears and it changes when I move my head or if I stand up. When you put all of those things together, then that starts to turn into a diagnosis. We're not just looking for like one thing that checks the box and then we give you the diagnosis. So this is another thing that can happen. Doesn't mean it will for everyone, but we see that this optic nerve can start to bulge out. So this is like another version of looking at that papilledema. So in a normal one, like on A, you see how that optic nerve comes into the back of the globe of the eye, and that back of the eye just looks smooth, right? But in B, you can see how this optic nerve right here is coming in, but it's bulging into the back of the eye. And this is what we're looking at with papilledema. That's the bulge. That's the pressure that's being placed on the outside of this optic nerve from the pressure accumulating inside of the skull. Okay? Excuse me. If we scroll down more, you can see where we start to get with a thing that's called tortuosity of the optic nerve. And that means that you have this thing that looks like a band, right? You see, I got a string over here we used for a heart thing earlier. So if I got this string and there's pressure on it, it'll bend. And so what you're looking at is this optic nerve. It should look like this, like an A, right? Where the optic nerve is kind of like a straight line. It makes a V headed toward the middle between the two eyes. In B here, you see how it looks like it's almost got smeared or smudged. They actually call this a smear sign. And you can see a bend in that optic nerve. Turns out shouldn't be a bend in there. And sometimes people will also experience when the pressure is in this part of the eye, they will feel pressure in the eyes and they may feel more pressure of the headache when moving the eyes, as we're creating like different orbital pressures by moving the eyes. So that can be just like a little helpful sign as well. Another one to look at is you can actually see on that optic nerve, you can see this really white part around the optic nerve is showing you the cerebrospinal fluid that's like leaked its way around that nerve. It's just trying to go everywhere it can. It's like water in a flood, and you can see it here on the MRI. Another thing that you might find is that when you look at the back of the eye, we looked at this normal one, so you get this nice round globe of the eye, no protrusion of the optic nerve coming in. In B, in the one on the right, you can see that this, if you go from back to front, you can see it's almost getting sat on like a beanbag. So it's squished on the bottom where you see that pressure coming in again. So this is the flattening of the optic globe. And it's kind of worth just looking at all of these things because most of the time, if your symptoms are at a stage where it's like, this looks like it might be IIH, a CT or an MRI is going to be the thing that you look at. So we're going to be able to take a look at these things and see if there's anything there. And that's why it's important to kind of just know what these options are. A good radiologist will pick these up, no problem. But you're not looking for like one silver bullet. You're looking at how this whole constellation looks. And are we seeing evidence that it looks like there's increased pressure over time? If it warrants, then we kind of do things that basically looking at a lumbar puncture to see if that pressure is high. And then what they'll typically do is drain a little bit of the fluid off and see if that makes the headache or makes the symptoms feel a little bit better. Now, next level stuff, like the newer stuff people think about, is we have the ability to look more at vasculature in the head. And so we can look at things like, I'm going to skip the slit ventricle sign just because, but we can look at the vascular stuff here. I'm skipping the other part because it's more like a remnant feature. But this allows us to look at the veins. So these are actually the veins, which is kind of cool. A is the normal, that drain your brain. So all of the veins that go everywhere, collecting blood to bring it back down to the heart, they travel in these two big sinuses. And that's the sinus is just like a big river. So this is the one that splits down the middle of the brain. And there's one that goes off to each side. And these are the transverse sinuses. And the one that goes down the middle is called the sagittal sinus. And so they loop around and then they head down and go down through the internal jugular vein. Now in B, you can see where this little spot where it kind of gets pinched. And that can happen again because we get pressure. Veins don't have nearly as much pressure in them as arteries do. It's more of like a passive flow rather than an active push from the heart. So they have more likelihood of actually experiencing some compression. And when that happens, we get a buildup of fluid in these sinuses, and then that can cause pressure as well. Okay, so just kinking the hose on the drainage. And you can see they tend to look blotted, and that just means swollen, like the veins are just filling up the river. Like it's going to overflow, and then that can be problematic as well. These are really important, but we also may find that there can be compression of the internal jugular vein, which can happen in the neck, which can back up some of that pressure into brain. And then this is where you see different postures, laying down versus standing, or different head positions as someone turns their head or is in different positions while they're on the couch or wherever they may be in the system, and then cause a backup into the brain as well. But these are a little tougher because whatever position you're in the MRI may or may not bring out where that jugular compression is happening. So sometimes we have to look at them in a little bit more dynamic ways. This is where upright can be helpful, although sometimes you can't see the vasculature, or a Flonar MRI can be helpful to look at CSF flow as well. So with IIH, there's now hopefully you have a little bit more of an understanding or maybe a visual of some of the things that we typically are going to look at in trying to understand where you are, what's going on, and how do you start to solve it. And maybe this gives you just a little bit more understanding of how to pursue that, what things we want to look at. And then once we know those things, how do we then start solving backwards and figuring out what is the thing that we're going to do for this person? Is it going to be simply trying to resorb some of that CSF using medication? Are we going to try to do things that are postural related to the flow and the ability of the drainage to occur? So this is where, upper cervical chiropractic has really shined in the past, where understanding tonsillar invagination or pressure that's created on the cerebellum down into the foramen magnum becomes really helpful. And so these different tests that are relatively easy to get a hold of, starting from simple bedside to an MRI to a lumbar puncture, can really open up the clinical window and help people understand how to help themselves if this is something they're worried about. So I hope that's useful and helpful. If it is, let us know. Give us a comment. Let us know your story. Let us know if this is useful or any questions you have. It helps people be able to see the video, as you know, because YouTube's been around a long time. And we'll look forward to the next video. We'll see you again soon.